Good evening and welcome to Hello, It's Us, a program that tries to emphasize that we're all part of a group and not just individuals running around on our own. Together with my co-host Keith Ruff, we'd like to welcome our guest tonight. Tonight we're having 3 different episodes on epilepsy. The first with a group of doctors from the University of Iowa to discuss the Iowa Comprehensive Epilepsy Program, and I'll let them introduce themselves.
Hello, I am Dr. Charuta Joshi. I'm an associate professor in pediatric neurology and the director of pediatric epilepsy.
Hello, my name is Mark Granner. I'm a professor of neurology at the University of Iowa. I co-direct the Iowa Comprehensive Epilepsy Program and am medical director of the inpatient epilepsy monitoring unit.
I'm Matt Howard. I'm the head of the Department of Neurosurgery, and I'm a neurosurgeon who performs epilepsy surgery.
Very cool. And our first question is, for whichever one of you knows it, can you describe the mission of the Iowa Comprehensive Epilepsy Program for us?
Well, I think we all know the answer, but I can launch into that and the others can join. The purpose of a comprehensive epilepsy program in general is to provide the broad, full range of services to people with epilepsy and related seizure conditions, beginning with introduction to the medical center through clinic, assistance with diagnosis, specialized testing, treatments that range from medication, in some cases to devices and surgery, but especially to do this in a multidisciplinary sort of way. Where people come together from many different departments, many different disciplines inside the medical center, and also helping connect the patients to resources outside the medical center.
Either of you want to add anything?
No, I think that summarizes it.
Yeah.
Okay. What are the features of the center?
So the Epilepsy Center includes clinics in neurology, pediatric neurology and neurosurgery, where patients will see physicians in these specialized areas of medicine. We have nurses that are specialized in their approach to epilepsy, both in clinic, who help manage outpatients, not only when they're in clinic, but when they're at home and have questions that they call in for, as well as specialized nurses on the inpatient unit, where we bring patients in when they're having trouble with control of their seizures, and we might need to adjust medications, evaluate them for surgery, perform more specialized diagnostic testing like video EEG recording, where we actually bring people in the hospital, sometimes take them off their medicine and make them have, I shouldn't say make, allow them to have their seizures. Sounds a little bit crazy. I was talking with some colleagues at a different medical conference a few weeks ago, and I said, you know, what we do on our unit's really very strange, because you don't bring people into the cardiac unit and make them have a heart attack. That would be a bad thing. But we often purposely bring people in the hospital, and by reducing their medicine or having them stay up to miss sleep, allow them to have their seizures. Because by doing that and recording them with tests as specialized as the EEG recording, and sometimes even doing the EEG recording inside the head, as Dr. Howard performs, that we can learn a lot more about where the seizures are coming from and how we might better treat them. We have services in radiology that include CAT scans, MRI scans, things called SPECT and PET scans. We work with a really outstanding group of neuropsychologists who test memory and thinking and other functions of the brain, not only to help us make decisions about treatment and surgery, but to help monitor people's courses through life and to understand what their functional abilities are, and also help connect them with some resources in the community that might help them with things. So it's a big, gigantic team effort, and it's really something that spans a lot of different components in the hospital. Maybe Dr. Joshi could speak to what happens on the pediatric. That's largely the whole thing in the adult side, but there are also a number of services through pediatrics.
So we have a very similar clinic setup on the pediatric side, but in addition to what we do on the adult side, we also are the only center in Iowa that does the ketogenic diet. So this is a very different approach to treatment of epilepsy for patients that don't respond just to the standard medications. They could change their diet to a very high-fat diet, and we have a dietitian that is dedicated to the ketogenic diet. once a patient is admitted to the hospital for the diet, it takes between 28 to 36 hours of coaching, mostly done on the phone once the family goes home, till the diet can be assimilated as part of the family. We also have a ketogenic diet clinic that happens about twice a month, where I work with an advanced nurse practitioner, where we bring in only those patients because they have specific labs and then people don't get missed. So this is in addition to what's already happening on the adult side.
You want to describe a little more what the diet is?
Oh, absolutely. So in a very simple way, if I needed 1,000 calories per day, then to grow, 4 parts of that 1,000 calories would come from fat. And then the remaining 2 parts would come from a combination of carbohydrate and protein, which means when you are in the ketogenic diet, even a slice of bread is too many carbs. The other day I was walking by the cafe and I saw a small bag of Twizzlers that has about 30 grams of carbs in it. That would not be allowed on the ketogenic diet. So it is hard, but it is miraculous when it works, and it can be done.
And that causes a reduction in seizures or
Absolutely.
stops them? Or?
Absolutely.
Wow.
And how long do they need to stay on the diet?
So initially, we try the diet out for 12 weeks, which is 3 months. Most of the patients that are admitted to the hospital, and the reason we admit these patients is because we give the diet even to babies, and when adults get hungry or become hypoglycemic, we know to tell someone that we feel hypoglycemic. A baby may not be able to, so we admit them to monitor sugars. The admission lasts between 3 to 5 days. By then, the patients that are going to respond have already responded. As a result of which, by the time the family goes home, a lot of them are already committed to the diet because they know that by the time the child came into the hospital and 5 days were over, they are more alert and they are out of that encephalopathic state. A lot of them that came in seizing several hundred times a day are not seizing anymore. As a result of which, the first 3 months are not as hard as they seem initially. For the patients that don't immediately respond, 12 weeks allows us time to fine-tune the diet, and if by that point patients don't respond, we switch them back to their normal diet.
That's incredible.
Is the diet a lifelong commitment for some patients?
No, it is not. The diet is a lifelong commitment only to the patients that have a certain metabolic disorder called the glucose transporter deficiency and certain mitochondrial disorders where their brain does not utilize glucose but needs the byproduct of fat called ketone bodies to survive. But for most other patients that have medically intractable epilepsy and who are not surgical candidates, they would use the diet for about 2 years. What we find is even after we eliminate the diet, there have been neuromodulatory changes made to the brain such that the seizures are much less severe even when the patients go back to normal diet. So the commitment is 2 years for most patients.
Is there a difference with age? If they're younger, is there a better chance for it not to come back?
We're less sure that the diet works for adults.
Okay.
It's been shown in studies to work well for kids, but we don't quite know what it does for adults.
Okay.
And as a high-fat diet, it's not necessarily the most healthy thing for an
No.
adult to stay on. Different story in kids, I imagine.
Absolutely. I think when it comes to neurodevelopmental outcomes, these patients that are in a trance-like state from seizures are suddenly more alert. For the patients that are lifelong committed to the diet, when we put them on the diet, we are monitoring their cholesterol and their triglyceride levels because the diet gives you normal calories. For most people that eat a high-fat diet, they also overeat and don't have healthy lifestyles. For the children, they only have calories that they need to grow and that are adequate for growth. So most of these children are not overeating. Plus, we are monitoring their lipid profiles.
So describe an average meal on this diet. I'm having trouble trying to put together what this
Absolutely.
plate looks like.
Think of a can of Crisco, right?
Well, for breakfast, a child may have scrambled eggs with hot dogs, may have a couple baby carrots on the side. For lunch, they may have a chicken breast or a salmon fillet, a little bit of lettuce on the side. For snack, they may have 3 to 4 macadamia nuts. For dinner, they would have probably eggnog to drink, and another set of some hot dog, chicken, creme brulee kind of dessert, but something that is high in buttercream or made with buttercream. So instead of flour for their birthday cakes, they would use almond flour. Or they could make the cakes from a formula that comes in a powder called the KetoCal formula, which is balanced in a 4:1 ratio.
So
I
some
can see
definition.
why it would work better on kids.
Yeah, I couldn't do it. So some basic definitions and numbers might help put all this in context, right? So a seizure is basically a short circuit in the brain's normal electrical activity. All our brains are doing electrical things right now as we think and see and talk and have emotions. But a seizure is sort of a short circuit in that activity where there's too much electrical activity going on at that moment. And where the seizure comes from in the brain will determine the sort of symptoms that a person has. So people can have a seizure where they just stare blankly off and lose time for 5 or 10 seconds. Or they can have movement in one arm but not the other. Or they can perceive a vision or a sense or a smell. They can lose awareness, or they can have a grand mal convulsion where they stiffen and shake all over. So there are all sorts of different kinds of seizures. Some seizures don't come from epilepsy. They come from a different health condition in the body, like a low blood sugar or a reaction to a medicine. But epilepsy is when the brain makes the seizures happen, either born with it because of genetics or acquiring the seizure condition because of some injury or change to the brain. And it can happen at any age. It's a condition that affects babies even when they're still in the uterus, and it's a condition that can affect 80, 90, and 100-year-olds. So we see people of all age ranges with this. In America right now, there are about 2 million people with epilepsy. So if you took them and had them live in one city, that would be Chicago. That would be the representation of how many people in the U.S. have epilepsy. In Iowa, about 30,000 people have epilepsy right now. So it's a relatively common condition that is frequently encountered in the community, in the workplace, in schools, in emergency departments, in everybody's doctor's office. You know, family doctors see this. Sometimes they're the very first people to diagnose it. But neurologists and neurosurgeons stand by as specialists to help when the condition either needs to be diagnosed in the first place, or maybe the treatment hasn't worked out when the family doctor tries the first thing around. We have a number of medicines to try to control the seizures of epilepsy, but we don't really have a medical treatment that takes the epilepsy away, that takes away that tendency to have seizures. Now, time may do that, and surgery may do that, but the medicines really just treat the seizures and try to prevent them from happening. And luckily, they're successful about 2/3 of the time, which means unluckily they don't work about 1/3 of the time. So there are people that resist treatment with medicine, and that carries a lot of complications with it. Folks that have uncontrolled seizures under state law can't drive a car. They might find it more difficult to finish school or to live independently or to navigate the challenges around the community or in the workplace. And that's when they need to get plugged into specialty care and other sorts of resources that can help with those things.
Amazing. What does an epilepsy center offer that's not otherwise available in the community?
I think several things would include people with a special interest in helping this condition. We've all spent years of our professional lives training to do this, and then years after that working on our craft in this field. And we specialize in this field, so we have a bit more expertise with it in terms of diagnosis and particular treatments. You will find resources like special diagnostic testing. The epilepsy monitoring unit we have is the largest in the state of Iowa, where people come in and have the test done to figure out their seizures. We have a special room devoted to Dr. Howard's work, where patients come in who are about to have surgery on their brains and have electrodes actually placed inside the head through an operation, who can come in and have very specialized testing. It's the only place in the state where that can be done. And then connecting to social workers and educators and pharmacists and nurses and psychologists and all sorts of other people that really have this as a focus of their career.
So for people who are potentially capable of benefiting from epilepsy surgery, the University of Iowa in this region is where you would come for that care because it's complicated and you need to have doctors from all different disciplines work together to determine who would be a good candidate for epilepsy surgery. And basically that boils down to patients having to fulfill a number of criteria. They have to have persistent seizures despite optimal medical management. They have to be in a social situation where being seizure-free is going to make a big difference in their lives. So for most people that means work opportunities, being able to drive, things that they can't do because of their seizures. Then those are people we think about for epilepsy surgery. And then the third criteria is that we have to be able to find and be certain there's a seizure focus in a portion of the brain that we can safely remove. So the surgery is targeted at removing the part of the brain that's causing the seizures in most instances. And though it's a complicated and very serious undertaking, we're doing this all the time. As we speak right now, we have a patient in the hospital who has electrodes in the brain who are preparing for epilepsy surgery, just as an example. But it's a very attractive option for certain people because, for example, if you're continuing to have seizures, if you have medically intractable epilepsy, you have a significant lifetime risk of sudden death. It's a very serious problem. And besides not being able to drive and do these other things. And if you are a good candidate for epilepsy surgery, for example, if your temporal lobe is where this focus is, if we resect that temporal lobe, there's about a 70 to 80% chance that you won't have seizures anymore, as measured a couple years after the operation. And that compares to a less than 10% chance of being seizure-free by trying new medication based on historic results with different medications. So epilepsy surgery is a very, very important treatment option, but you have to come to a big center to determine whether you'd be a candidate for that. And we know from the statistics that Dr. Granner was just mentioning that in the state of Iowa there are thousands of patients who are not being evaluated, who need to come in and figure out whether their seizures can be eliminated or not. And so you have situations where a person has a few seizures, they tried a few medications, but they're still having seizures periodically, and they're at risk of these very, very serious complications. So to the extent that a show like this can get information out to the public, I think it'd be great if people recognize that if they're having persistent seizures, they should come to a comprehensive epilepsy center.
How far can one patient go when he or she becomes immune to any medicine they give him or her?
It's not really an immunity problem, but it's just that the medicine doesn't work for them.
Yeah.
So I mentioned that 2/3 of people will find good control of their seizures with some tries of medicine. Often it's the first, about half the first medicine works, and that's it. That's great. Of the other half that don't have good control, another about 15%, the second medicine works.
Okay.
So we're up to 65%, about 2/3 there. After you've been on 2 medicines that are chosen for the right kind of seizures, they're picking the right medicine for the right kind. After 2 medicines, the chance of becoming seizure-free on any medicine after that is only about 4%. So that's when we sort of draw the line and say, this person is very likely to be resistant or refractory to further medicine. And then we, after 2 medicines and still having seizures, as Dr. Howard points out, you really, we would love to evaluate all those folks through clinic. It may turn out that we find out their seizures are coming from something else and there's a different way to treat them. We may find that they have a kind that can't be treated with surgery because they come from too many areas or from the whole brain. But we might have some other options for them too, like devices like the vagus nerve stimulator.
Yeah.
But we might find that a certain group of them are really good candidates for surgery with a high chance of success and a low chance of risk.
We see that all the time. People who were seizing and didn't think there was an option, and they're just going to have to keep seizing. They come and they're evaluated thoroughly, have the surgery, and their life has changed.
In one study, the average time from the diagnosis of epilepsy to actually getting to the Comprehensive Epilepsy Center was 18 years.
Wow.
And it doesn't take 18 years to figure out.
It's a public information problem.
Yeah.
So the shows like this are great. There's just a lack of understanding out in the community that you don't have to live with necessarily with persistent seizures.
And I think medical intractability to most of us means about 2 years since seizure onset. If you've not gotten good control, it's time to come to a tertiary center. Most of us would agree that waiting 8 years or 9 years before you come to a tertiary care center is too long.
Yeah.
I mean, for an adult, one seizure every 6 months takes care of your driving. You wouldn't be able to drive if you have a seizure within a 6-month period. So 2 seizures per year are too many for a person that's on the road.
And am I correct, the more seizures you have, the more damage is done to the brain?
To the brain?
Yeah.
You might. It's a really hard thing to measure.
Okay.
We know that in the laboratory, when people study this in laboratory mice or rats, you can do that. You can make them electrically have seizures and then more brain injury gets produced. We suspect that happens in people. We have some ways of measuring that, like through memory testing, the neuropsychological testing. You can see that people year after year after year decline a little bit in short-term memory and things like that. The other thing that I think we really know for sure is that the sooner you can try to fix the problem, the better off a person's life will end up being. As Dr. Howard correctly pointed out, sometimes people that have a lot of seizures, or sometimes even not very many, they carry this increased risk of having what's called SUDEP, or sudden unexpected death in epilepsy. And that happens about 1 out of 1,000 people per year. So I have a clinic that has 500 to 1,000 people in it, and unfortunately I could expect that I might lose one of them each year from this. So we like to try to, of course, make a person's life less risky. We also know that the sooner their seizures are brought under control, the better their chance of finishing schooling, getting a job, driving a car, living independently, and they're having seizures and having epilepsy through life. Still carries, unfortunately, a public stigma to it, as people don't understand the condition very well, which is also why a program like this is really, really helpful. But we want to make sure that people can live as fully productive and high a quality of life as possible.
Is the lack of knowledge about this because the rest of the medical community in the state doesn't know enough about it to make a referral, or that social workers don't know, or insurance companies don't want to tell about it, or what?
And it's not just Iowa. It's a national problem that people don't understand that epilepsy surgery is a potential curative treatment option for people who are having intractable seizures. So it's many of our patients, the general practitioner really wasn't aware of it because they're reading about so many different things. People coming in with pneumonia, people coming in with skin problems. They have to be up to speed on all these different fields, and they're not necessarily aware of what we know as specialists in the epilepsy area. So we'll have patients who heard about from a newspaper article, come in, get evaluated, get treatment, and are fixed. So there's a real problem with communication at multiple levels and understanding of what can be done for these patients.
You said that the university is the only location in Iowa where this program is at. How does that relate to other states? Is one location in the state pretty average, or do the bigger states have more?
These are very resource-intensive centers. You need a lot of different people, and the imaging equipment, for example, is very expensive and specialized. So in the state Iowa size, you'd expect one center.
Kind of related to the number of teaching hospitals.
It's
Or the
basically
number of
connected.
patients.
Yeah, it's population-based and it's teaching hospital-based. So in Chicago, there would be, what, 5 maybe, 4 or 5. I'd have to count.
Alabama, one of our colleagues just came from the University of Alabama,
Yeah.
one place,
Yeah.
University of
Montana,
Alabama.
Wyoming, all served by the University of Washington. And there's several states come into one place there out in the Pacific Northwest. So it's population-based, it's resource-based, and there are some private-based centers around the country, but it's mostly at a teaching hospital where you find this.
What kind, if any, innovations are on the horizon for epilepsy?
So, there is always some new medications in the
Yeah.
pipeline, but I think what we've discovered as a number of new medications have come out the last 15, 20 years is that the new medicines are safer. They have fewer side effects. They have less
Okay.
interactions with other medicine. They're less likely to make people groggy or drug feeling, but they don't necessarily work any better than the old medicines like phenobarbital, Dilantin. So safer but not more effective, so we need better medicine treatments. I think the next decade or 15 or 20 years is going to be pretty device heavy. I think we already have a device now called the vagus nerve stimulator implanted under the chest that stimulates the nerve in the neck and sends impulses up to the brain to reduce and control seizures, but it usually doesn't take them away completely. And around the country there are a number of centers that are working on devices inside the head to stimulate the brain, either the brain surface, or you may have heard of deep brain stimulation for Parkinson's disease, so something similar to that where we electrically stimulate. Companies are working on devices that can detect or even predict when a seizure might happen by looking at the the EEG activity, the brainwave activity from a recording. And maybe eventually we'll have a device that's implanted inside the body, inside the head, and it's all completely closed in, where this device watches the brain activity, predicts that a seizure might be coming up in X number of minutes, and then does something about it, like an electrical stimulation or cooling that part of the brain or delivering a medicine to that part of the brain. So I think my personal feeling is that the next decade or so is going to be very device intensive.
Yeah, I agree.
We're going to have to steal a few minutes from one of our next segments because we're not going to finish all our questions
Sure, we can roll
today.
that in.
We certainly want to thank you all for being here. It's a fascinating topic. The rest of you, we'll see you again next week.
Thanks for inviting us.
Yeah, thank you.
Appreciate it.
You're most welcome.